Okay, good day, everyone. My name is Danny Weiss. I'm a neonatologist at Sunnybrook Health Sciences Center in Toronto and co-chair along with Dr. Danielle Rios of the Neonatal Hemodynamics Research Center Targeted Neonatal Echo Foundations Curriculum. Welcome to our latest monthly seminar, for which we have a fantastic speaker, as always. I know people are trickling in, but I'll go ahead and start with our introductions. I do want to first acknowledge Mallinckrodt Pharmaceuticals, who supports the TNE Foundation's curriculum with an unrestricted educational grant. Just a reminder to everyone to please complete the session evaluation. This QR code will come up during the discussion period after Patrick's talk today, so please do complete an evaluation. And of course, a not so shameless plug for the upcoming inaugural Dr. Reagan Giesinger Clinical Cardiopulmonary Physiology for the Care of the Sick Newborn course. This is a course that has been done previously. It has been renamed posthumously for Dr. Giesinger because she was such a giant in the field. I encourage you to snap that QR code and please register for this fantastic course that is coming up in October. So without further ado, it does give me great pleasure to introduce today's speaker, who really needs no introduction, but I will do so anyway. Dr. Patrick Mcnamara is speaking today on PDA physiology, and he's the director of the Division of Neonatology and vice chair for inpatient acute care at the University of Iowa Steed Family Children's Hospital. He's a professor of pediatrics and internal medicine at the University of Iowa and the current chair of the PAS Neonatal Hemodynamics Advisory, as well as a number of other prominent groups. We all know him through his clinical and research interests, which include myocardial performance in the setting of PDA, pulmonary hypertension, and of course the use of targeted neonatal echocardiography. Patrick, we have a full house of people eagerly awaiting your talk today. Thank you so much for taking the time to speak with us on, I hope it is and what will continue to be one of your favorite topics.
Thanks, Danny. Can you unshare? I can't get in here. Okay, fantastic. Give me 1 second. All right. Can you see the screen okay? Yeah, all right. Okay, so I'm not sure, is this the first session of the new calendar year or the second one, Danny?
This is the second. Yeah, we had Phil did kind of introduction to targeted neonatal echo in July.
Okay. All right. So thank you so much for kind of allowing me the opportunity just to share some thoughts and perspectives on probably what is the most controversial topic in modern kind of not just hemodynamics, but I would say neonatology in general. First, I'm at home, I'm off this week, so I actually occasionally take a day off. So today is one of the days I'm off, although I'm never really off, as you've seen from earlier this morning, Danny. But I'm telling you that just in case someone decides to mow their lawns, which has happened to me before when I'm giving a talk. So if I have to get up and change my room, that's what's going on. So, all right. So without further ado, so I like to put this slide up because, you know, if you are a purist and one looks at the evidence to date, okay, one may decide that the evidence is clear. There is no role or benefit to treating the Ductus arteriosus. So this is the end of the talk, okay? And some people may conclude that, but I have to talk for 45 minutes and I'm going to perhaps give you an alternative perspective on this, because really and truthfully, the devil is in the detail. And I think we've come a long way in neonatology and our understanding of the importance of evidence, the importance of science. But from some respects, there are aspects of the interpretation of evidence that we actually have kind of lost sight of. And I'm going to start off with this commentary from the editorial by Dave Sackett on what is evidence-based medicine. And there are some really, really important comments here that I think that are really worth thinking about. So what is evidence-based medicine? It's the conscientious, explicit, and judicious use of evidence in making decisions about the care of individual decisions. And if you read on further, Dave says that good doctors use clinical expertise and the best available evidence, and neither alone is enough. Without clinical expertise, practice risks becoming tyrannized by evidence, for even excellent external evidence may be inapplicable or actually inappropriate to an individual patient. And without current evidence, practice risks become rapidly out of date to the detriment of patients. So if we now look at the literature and look at the interpretations by many that there really is no indication to look for a PDA, never mind treating a PDA, and we now think about what is evidence-based medicine, well, then there's a series of questions that we need to ask. Firstly, are we certain that the patients in the trial have the disease? Okay. Second, did the disease, meaning the PDA, persist for a reasonable duration of time? Thirdly, did the treatment cure the disease? Did it go away in the group that were allocated the intervention? So was it effective? And then finally, do parents actually care about the outcomes that we have used in our trials to adjudicate treatment efficacy? So let's look at where we are in the year 2024 in modern neonatology. And more babies are surviving, yet some of the important and common morbidities, such as intraventricular hemorrhage, BPD, and in some centers, necrotizing enterocolitis, we've made actually not a lot of progress. And, this graph here on the right-hand side shows that, for some gestations, particularly at the extremes of prematurity, the rates of intraventricular hemorrhage, which is severe, can be as high as 35 to 40%. Okay, and we'll come back to that later on. Another piece of consideration, this is some work from Jan Millet in Dublin, which is some natural history data in which you use non-invasive cardiac output monitoring and identify that babies who had a stable cardiac output during the first 2 to 3 days after birth were less likely to have major morbidities in the first postnatal week. And these included intraventricular hemorrhage, pulmonary hemorrhage, and so forth. This is a recent large kind of population-based data set from the pediatric database. And again, this brings another important consideration here, is that tiny babies seem to be more at risk, at least based on blood pressure, for cardiovascular instability in the first postnatal week. And what you can see here is that the likelihood of receiving dopamine is actually higher than caffeine in the first postnatal week, suggesting that a lot of these babies have a lot of cardiovascular instability. So I'm going to start with a case, and this is not a case from Iowa. This is actually a case from Toronto. This happened. This is a real case about kind of a year or so before I left Sick Kids, and it was a outborn patient who was brought in, delivered at a community hospital for severe preeclampsia. The infant was in poor condition at birth, required aggressive resuscitation, multiple intubation attempts, and had evidence of metabolic acidosis on the cord gas. The initial respiratory course was relatively unremarkable, but fairly quickly the infant developed some evidence of hypotension, with in particular a low diastolic arterial pressure, for which the transport team started the baby on dopamine, increased it, and not only did the patient not get better, but the patient actually got worse. Further drops his blood pressure, at which point they added some epinephrine. So by the time the baby arrived at Sick Kids, it was probably 6 to 7 hours of age. I remember vividly the day we reviewed this baby on handover, and we talked about the likely cardiovascular physiology and the likely causes. At Sick Kids, we would have a a daily discussion, which was case-based, and people came out with their thoughts and perspectives: septic shock, perhaps heart dysfunction, maybe subclinical pulmonary hypertension. And I remember one of the residents actually saying, could this be the ductus arteriosus? And my comment at this point in time was, no, this baby is 8 hours old. I don't believe it's biologically plausible that a PDA could be responsible for refractory hypotension. Now, obviously, we had the ability to perform comprehensive echocardiography, so we didn't ignore the clinical symptoms. We actually performed an echocardiogram, and on that study, I was kind of a little bit shocked to realize that this infant had a ginormous ductus. And when we looked at kind of all of the various manifestations of QPQS abnormality and high volume shunt, you can see that the left heart is pressure loaded. If you compare left ventricular output as a surrogate of pulmonary blood flow, right ventricular output as a surrogate of systemic blood flow, which they are in the presence of the PDA, QPQS was 2-to-1. And there was evidence of compromised flow to the systemic vessels. So this surprised me to a certain extent at the time, because everybody had been lured into the pretense that all babies who are preterm have pulmonary hypertension of some degree, and the likelihood of manifesting major changes in QPQS is actually likely to be low. So we decided, based on our criteria, that we would start treatment. At SICAs at the time, first-line therapy was indomethacin, which we prescribed. And we also implemented strategies to limit transductal flow, given the fact that the pressure gradient across the ductus is really what's driving this shunt. And the baby got better. Within 24 hours, he was off all cardiovascular support, got extubated, actually within the next 36 hours. And on his repeat echocardiogram, the PDA was closed. So this was telling for me, because it suggested that there are perhaps patients who actually have major disruption in cardiovascular physiology that could be compromising end organ flow. And when we think back to the data from Jan Millerton, how much does derangements in hemodynamics physiology due to ductal shunt be influencing some of the morbidities we see? So we've come a long time, and if you think of our starting point, there's not much evidence based on the trials to date. Well, let's go back to 1956, and at that point in time, this was the first report that the PDA may be responsible for at least heart failure and respiratory morbidity. And Mostyn Powell reported 6 patients who had large PDAs who kind of were clinically getting sicker until they surgically closed the PDA, after which time the clinical course improved. The evidence for association, again, I'm not going to great detail. Sorry, you've got you need to mute. The evidence for association, is relatively strong. And there's a whole series of studies that you can find from the literature. The early work on the right from Bob Cotton showing that patients with larger shunts were more likely to require mechanical ventilation for a longer duration of time. Some work from Stephen Palder that showed that infants who had large PDAs at the time of the onset of NEC, reflecting probably shunts that were present for longer, were also more likely to die in that study. And the early evidence from the 90s and the 80s seemed to suggest that George Cassidy's study randomizing patients to surgical ligation on day 7, which again I think is important because it is a definitive closure, showed that the rate of NEC, although control rate was high, was reduced almost 4-fold. The early meta-analysis conducted by Ron Kleiman comparing early versus late therapy again seemed to suggest that not only did treatment reduce the likelihood of surgical intervention, but also benefited both respiratory and gastrointestinal morbidity. So when we look at this, it's then very difficult to understand how do we find ourselves today in an era whereby there's been a fairly significant secular movement away from both medical and surgical therapy, and an increase in the use of conservative therapy. And I'm not going to go into great details with conservative therapy, but even around that subject, there's a lot of uncertainty and a failure to differentiate that conservative therapy still is a form of therapy. It's the use of non-pharmacological measures to mitigate abnormalities in QPQS, just like as if you're managing a patient with single ventricle physiology. This does not necessarily represent kind of, absolute nihilism. They're two very different things. But there are some people that believe that the ductus is never a problem. If you talk to a pediatric cardiologist, they would say you're crazy. How can that be, given the fact that VSDs and truncus arteriosus and so forth present in a very similar manner, and we know that we need to close those patients. There has to be some logic, because some very intelligent people have said that we have to be cautious, and I think we need to pay attention to that. The first evidence that one has to be thoughtful, and that at least suggests that perhaps that not every patient needs treatment, comes from the natural history data. And this is some work, again, from the group in Dublin, in which they followed a cohort of patients. Now, important to recognize that the study is biased towards slightly bigger babies. There are more patients in this that were followed longitudinally, and many patients died in the less than 750 gram group here. So we don't actually have their data. So to project out what would happen to their PDAs is really impossible. But certainly what you can see is in bigger babies over 1,000 grams, a large proportion of them by the third postnatal week, more than 60%, have PDA closure. If you look at the smaller babies, however, you can see that it's a very different look. And it takes up to 50 days for 50% of those patients under 750 grams for their PDAs to close. The other important consideration that really has not been yet addressed satisfactorily is, how does closure occur? And even with medical therapy, I still don't believe we're sure, do the medications we use work on the ductus, or do they work on different manners? But certainly it is biologically plausible that some of these PDAs may not be closing by ductal remodeling, but by forcing pulmonary vascular remodeling, which will, just like with conservative therapy, increase pulmonary vascular resistance, decrease the pressure gradient across the PDA, resulting in ischemia to the ductal wall and potentially PDA closure, which is great if this is the endpoint you're trying to achieve, but isn't very good if it's at the expense of pulmonary vascular disease and pulmonary hypertension. Probably the most compelling evidence comes from Bill Bennett's meta-analysis, which very clearly shows that in the trials conducted, PDA treatment reduces ductal patency, but doesn't modulate some of the important outcomes that we're managing. So how do we reconcile this, and how do we interpret this particular data? There are some really, really important considerations that, that really we have not paid enough attention to. The first and the most important one is the adjudication of the problem. Up to 40% of the studies did not even have echocardiography to actually say that the ductus was patent. And many of the studies, including the more recent trials, Baby Oscar and Benedictus, which I'll come back to later, use just a single threshold to adjudicate hemodynamic significance. Echo is really important, not just for quantifying severity of shunt, but also for excluding clinical situations where closing the PDA would be harmful. Like the case in front of you, where you can see that the right ventricle is profoundly dysfunctional. This infant's pulmonary blood flow is dependent on a left to right ductal shunt. Closing the PDA would be very, very harmful. Plus, there are also situations in which the ductus is an innocent bystander, particularly during the transitional period, and closing really shifts the risk-benefit ratio from benefit to adverse effects of therapies. And this, again, is an important consideration we'll touch on shortly. So most studies have focused on PDA diameter, and this is problematic for a series of reasons. Firstly, it makes assumptions. Secondly, when many operators have looked at the reliability between observers, you can see that ductal diameter has got one of the worst correlation coefficients compared to some of the other measurements, at least in this study by Fernando Martins, conducted back in 2016 in Toronto. Another important consideration is that diameter only tells you a piece of the puzzle. In looking at the likelihood of deviation in all of these markers here, which tell you about the severity of volume loading or compromise to systemic blood flow, you can see that the R-squared values are low. And again, when we think of physiology, and we'll come back to that later, flow across a vessel is not just dependent on the diameter of the vessel. Diameter is very important, but diameter is dynamic. Sometimes we see during the course of an echo, PDAs getting bigger and smaller. Pressure gradient, viscosity, and length of the vessel are other key components of Poiseuille's law, which determines flow. The other key important consideration is that the ductus comes in all sorts of different shapes and sizes. All of these patients have left to right shunts, but you can see that they look differently. And why that's important is that when we're interrogating the PDA and measuring the size, sometimes we only use color, which can overestimate the size of the vessel. 2D is probably the best way, but 2D becomes less reliable once you get to measuring very small PDAs. But more importantly is we assume that the ductus in cross-section is circular. And as you can see from the following cross-sections, which are pathologic reconstructions of babies who died and their PDAs, you can see that the ductus comes in all sorts of different shapes and sizes. And why that's important is that you may overestimate or underestimate the size of the vessel. One of our interventional cardiologists at Iowa conducted this study with us kind of in the Echo Lab, where we looked at a direct correlation between echo estimated diameter and cath estimated diameter. And you can see in the graphs on the left-hand side is the aortic end. In the middle is the smallest end, typically the pulmonary, and on the right is the length. And you can see that there was fairly major bias. And if you're looking at the pulmonary end, that bias, as you can see from the data, may be up to 0.5 millimeters, which becomes really, really important if you're thinking of the limits of enrolling patients into studies. A 1.6 millimeter PDA could be 2 millimeters, or it could be 1.2 millimeters. So there's a real risk of enrolling patients with presumed shunts that one is concerned about when one may not be. It is not a guarantee that if you're in the control arm that you will receive placebo. The vast majority of studies, placebo therapy has been provided, even in the more recent PDA tolerate trial. Are the data from the Metanalyses Contemporary? And the answer is no. The vast majority of the trials are more than 20, kind of even up to 30 years old. We're in a very different era in which the patients who are really the most problematic represent the infants probably under 25 weeks gestation. We now have nitric oxide. We have a different approach to breastfeeding, breast milk, probiotics, et cetera, et cetera. So one can argue that the data is probably not really relevant in the year 2023. Now, in the past year, there have been two really important trials that have been published. And again, kudos to both investigators for the incredible work in pulling trials off. For any of you that have engaged in a randomized trial, it is not easy. It is really hard to enroll babies into trials, and particularly with PDA trials. Many of our recent trials, including the ongoing NRN trial, has struggled to enroll patients because of issues like physician concern and that they may be enrolling the wrong patients and so forth. So Equipoise is an issue. Both of these trials were relatively similar in that patients were enrolled based on a diameter 1.5 millimeters, but there was really no measure of true hemodynamic significance. The direction of flow across the ductus is reflective of the pressure gradient, but not necessarily flow. Both trials identified no difference in the composite outcome of death or BPD, and in the Ductus trial, there was a suggestion of harm with an increasing likelihood of BPD in the control arm. So how does one reconcile or interpret these data? Because these patients are more reflective of neonatology today. Either one, ibuprofen is an ineffective intervention or perhaps harmful, or the process of patient selection still remains imprecise. And if one thinks of, the challenges trying to enroll babies in trials, and you now think of a diameter of 1.5 millimeters as the threshold to enroll, it becomes very easy, to measure 1.6 versus 1.4 millimeters. So if we actually look at the studies, up to 50% of the eligible patients in both trials were not enrolled, again, suggesting a bias. We've already talked about the lack of true hemodynamic significance adjudication. Another important consideration is the rate of spontaneous closure in both arms is not entirely clear. And then finally, PDA elimination actually occurred only in half of the patients. So if you go back to the series of questions that I asked, did the patients have the disease? I'm not sure. Did we appropriately adjudicate? I'm not sure. Did the therapy have efficacy? And the answer is you really only eliminated the problem in 50% of the cases, which suggests that there is a high likelihood that patients with shunts that perhaps are not problematic could be enrolled. And some clues to this come from actually the post hoc analysis of the TIP trial, in which they actually looked at the population of infants who did not have a PDA. You can see, again, a similar trend towards, in the treatment arm, a higher likelihood of the composite outcome of death or BPD, which may lead one to believe that perhaps we are enrolling babies who have a high likelihood of spontaneous closure, in whom the adverse effects of therapy may be superseding any likelihood of benefit. Some further clues to this come from this very nice, elegant work from Ron Kleiman across PDA tolerate. And what you can see is the rate of spontaneous closure in enrolled patients according to center. And you can see that for infants under 26 weeks gestation, that ranged from 9% to 50%, suggesting that there's a lot of babies that may have spontaneous closure in this particular study. So again, important to consider that how does the PDA close? And remembering, this is my only biological slide in the study, is that the ductus intrinsically is very different to the mature ductus. On the top is a schematic of the preterm ductus. And unlike the term ductus, you can see the muscle layer is thinner. You lack the internal convolutions, which are important for apposition of the sides of the PDA. You also lack vasa vasorum. So the preterm PDA is not necessarily designed to close. And if one thinks that our drugs working directly on this thin layer of muscle, it becomes difficult to reconcile that may be the true mechanism, and that there may be other important modulators of closure across the ductus, as we will talk about later. Equipoise is an issue. We've seen it in PDA tolerate. Here you can see some work from Melissa Leibovitz that up to 40% of the enrolled patients were not randomized. And what was most interesting is that those babies were younger, smaller, less likely to have antenatal steroids, and sicker, but were treated early, and had lower rates of death or BPD. An important consideration, some personal communication from some of the clinicians at some of the sites where that people really only felt comfortable randomizing those babies who were less sick, who had shunts that were less problematic. The other important consideration is physiologic efficacy. And some clues to this come from this recent post hoc analysis of Afif Al-Kafash's randomized trial in Ireland, which randomized babies based on PDA score. And what you can see here is that in this post hoc analysis, the subgroup of infants in whom treatment was successful had a lower rate of the composite of death or BPD than the group in which treatment was failure, and also the placebo group. So this is an important consideration here as we look at data, is have we truly randomized, and not only randomized the right patients, but studied interventions that actually are likely to eradicate the problem. So then, if you don't have great evidence from randomizing patients, then one has to look for other ways of trying to interpret literature. And one of the best data sets, and there have been at least 3 data sets now from centers who have changed from aggressively treating the PDA to a non-interventional approach, which does not necessarily mean that you've done an echo and you're practicing conservative therapy. You're actually maybe practicing non-diagnostic based therapy. And this is Gabriel's work from Montreal, which really showed that the effect of non-intervention is most applicable to the less than 26 weeks population. If you actually look at the more mature babies, you can see that the death or BPD rate in those patients really didn't change very much. It was only in the group of infants less than 26 weeks where they saw concern. So BPD has been the entity that we've most tried to fix and adjudicate PDA based on. And some may argue that is this the most important outcome for parents? Do parents really care about an outcome that decreases your need for going on low flow oxygen for a short period of time? Are there more important metrics? But for what it's worth, it is what we have to take care of. The other important consideration is that there are many, many things that independently modulate the likelihood of BPD, ranging from antenatal factors to other postnatal covariates. So how do we think about BPD as a hemodynamics clinician? Well, firstly, there are many factors. Secondly, it's not just about BPD. As we learn more and more about this vulnerable population, the likelihood of pulmonary vascular disease that may be coexistent or independent of BPD and left heart phenotypes may play another important role. So how do we move forward? And I love this phrase, someone shared this with me recently because it really speaks to the mistake, and it is a mistake that we've done with our PDA literature. We've invested billions of dollars on trials without actually defining the disease, okay? And as Albert Einstein said, if I were given 1 hour to save the world, I would spend 59 minutes defining the problem. We have not spent the 59 minutes. Back in 2007, we kind of for the first time suggested that we need to stop doing trials based on diameter, that it is insufficient to differentiate pathologic versus non-pathologic shunts. It also increases the likelihood that you may be closing PDAs that have PDA supportive circulations. So we suggested that to better move forward, we need to look in a more comprehensive manner. And this becomes particularly relevant with respect to BPD. There are probably 2 things that are important: the magnitude of the shunt and the duration of the shunt. And in the face of excessive left to right flow, as you can see here at the top picture, this is flow in the pulmonary veins. You can see it's twice as high, the peak velocities, as flow in a patient with a closed PDA. Why this may be important is that it's not just about shear stress, but it's also about the delivery of excessive oxygen to the pulmonary vascular bed, which may increase the likelihood of remodeling of the immature pulmonary arterioles. This is a very nice schematic from Satyan, which really emphasizes the complexity of what we're trying to understand here, in that there is increasing flow, there's increasing pulmonary venous pressure, there's also shear stress, there's the effect of oxygen and the effect of mechanical ventilation in these patients, which probably all together work in unison to create this perfect milieu in which pulmonary vascular maldevelopment may occur. Probably some of the best evidence we have of a potential beneficial role for intervention comes from the primate randomized trial, where they demonstrated that baboons in whom they treated early and normalized QPQS, lung compliance at 36 weeks was improved, and alveologenesis was better in those baboons. Some further evidence for the important relationship of shunt and duration of exposure to shunt comes from Danny's very elegant work in Toronto in a large population of more than 800 babies. he demonstrated that the infants who ultimately ended up with surgical ligation, representing probably the most pathologic shunts, had much higher need for respiratory support, but they differentiated themselves very early on, suggesting that we may be able to identify with better ways those patients who are at greatest risk of long-term morbidity. The concept of duration of exposure was further emphasized by Ron Kleiman's work, who demonstrated that in ventilated patients beyond 10 days, increasing duration of exposure led to a significant and incremental increased risk of grade 2 to 3 BPD, which is really the BPD we should be most concerned about. The European study by Fernando Schena again showed a very similar finding, small sample size, but infants who had PDA ligation at an older age with higher PDA shunt severity score were more likely in this study to die or have BPD. We should not be surprised about the potential association with pulmonary vascular disease. We've known this since 1953. With the advent of cath closure, we are starting to be able to get more insights into the potential relationship to pulmonary vascular disease. Some work from Satyan and Memphis demonstrated that infants who had the longest exposure to shunt, group 3, took the longest time to recover the deterioration in respiratory severity that occurs after PDA closure. But more importantly, they demonstrated that those infants also have a much higher baseline pulmonary vascular resistance, suggesting that prolonged exposure could come at a cost. Two recent publications, one from Chen and a large study from Sam Gentle in the Alabama group, demonstrated very clearly that prolonged duration of exposure, particularly over 28 days, was strongly associated with an odds ratio of 7.9 with increased risk of pulmonary vascular BPD with pulmonary hypertension. So how do we move forward for the last part of the talk? Well, I think we need to recognize that there are morbidities in the first 7 days that have been associated with PDA. And if one only treats beyond day 7, it's not possible to mitigate those risks, those morbidities. There are later morbidities such as NEC or BPD, which are also associated with PDA. However, there are many other covariates such as mechanical ventilation, nutrition practices, infection that may also impact these risk factors. So to try to truly identify the population of benefit will require very carefully designed studies. For me, the ideal trial requires the randomization of patients who have high volume, high risk shunts with a low likelihood of spontaneous closure, and randomizing those patients to an intervention that is successful versus leaving those patients exposed to the problem. This is probably the only way we can solve this issue. So I mentioned that there are morbidities that happen in the first week. Some work from Anna Selmar in Denmark on a population-based study showed that the presence of a large PDA on day 3 was associated with an increased risk of death, severe interventricular hemorrhage, or NEC. The challenge that we face is that the clinical symptoms that are associated with PDA, so pulmonary overcirculation, may lead to an increase in oxygen requirements, need for mechanical ventilation and more support. Systemically, there may be a drop in the postductal systolic blood pressure. And if you're more of a purist, you will demonstrate a difference between the pre and the postductal systolic pressure. But there are other things that can give you these same symptoms, which makes it difficult clinically to differentiate those patients who are at risk of these long-term morbidities. Some further evidence from the imprecision of clinical exam comes from the study by Kindler in the UK, when they looked at what clinical factors predicted the presence of a large PDA on day 7. Only metabolic acidosis consistently predicted a large volume shunt, not heart rate, not blood pressure, not pulse pressure, and so forward. So we have a problem. So I presented a case at the beginning of an infant that surprised me. And in 2018, I moved to Iowa, which is a remarkable NICU. And they had published, their data on infants born at the limits of viability with incredible survival rates, as you can see from the graph in front of you. Iowa is in yellow. The red is the rest of the Vermont-Oxford network. And you can see as you go below 26 weeks gestational age, the likelihood of survival advantage increases. But there was still a relatively high instance of IVH, better than what you saw on the first slide, not 35%, but still 20%, a neck rate of 6%, and a very high need for surgical ligation. Now, the benefits to Iowa are not just about hemodynamics. There are many unique practices that I don't have time to go into today, but those include a dedicated neonatal critical care unit with one-to-one nursing for the first 2 weeks. Not all faculty work in the critical care unit. You need to be a true intensivist. A practice of first intention, high frequency ventilation. Early extubation is not the goal of care for these tiny babies and so forth. Can we further modulate this risk? The two questions that we asked: is there a benefit to early hemodynamic screening? And within this, should you treat the PDA? Like anything, different strategies have different risk benefit. So if you go with a prophylactic approach or early targeted prevention just based on diameter, one may be able to positively mitigate hemorrhage and IVH, but you're also going to run the risk of overtreatment. Most centers practice targeted intervention, but in those centers, the age of diagnosis tends to be beyond the first 7 days. So you're less likely probably to modulate NEC or BPD, and your ability to impact IVH or pulmonary hemorrhage is 0. And the further out you go, the less likely you are to mitigate against these interventions. We know that prophylactic indomethacin decreases death or severe IVH and PD ligation, but doesn't change neurodevelopmental outcome. Now, everybody on this call will agree that death and severe IVH are bad things. We don't want them to happen. We counsel parents that these things are bad things. But why do we not see a benefit? One of the possibilities may be that when you practice universally, are we exposing babies to morbidities or to disease processes that are PDA supportive? This is some of the early data from the iOS screening cohort, which demonstrated that there were up to 30% of infants had subclinical LV dysfunction, ORV dysfunction, pulmonary hypertension, and so forth, where maintenance of the ductus is life-saving. So if you give those patients PDA therapy and close their PDA, one may likely to cause harm. One of the other evidence for the important role of the ductus in early hemodynamics comes from this post hoc analysis from San Francisco, where they stopped using prophylactic indomethacin and demonstrated very nicely that in the conservative era, the likelihood of refractory inotrope resistant hypotension was higher, and those patients were much strongly associated with the presence of a moderate to large PDA on day 7, suggesting that, like the case we presented, that PDA may be a major cause of hypotension and hemodynamic instability, and rather than give those patients dopamine, which if the etiology is PDA, one may compromise end organ morbidities. Some very nice work from France, Jean-Christophe Rosé demonstrated that centers that screened were more likely to have lower mortality, with a number needed to treat to prevent one death of 23. One of the next studies looking at the impact of early intervention is Martin Kluckau's DETECT trial, in which infants were randomized at 6 hours to indomethacin or placebo, but just on the basis of diameter. This unfortunately was underpowered, as this was at the time we ran out of indomethacin across the world. But despite this, they showed a significant reduction in pulmonary hemorrhage, which is not a good thing because it's commonly associated with IVH. But interestingly, in the indomethacin group, there was a hint, numbers are very small, but a hint at lower significant IVH. So how might there be a relationship between what's going on physiologically with the PDA and the etiology of IVH. Well, we know that after birth, once the placenta is eliminated, there's a major changes in loading conditions. So the left ventricle, in the face of high afterload, may have relative dysfunction, and the brain may see low flow. If the ductus remains patent, and as we decrease pulmonary vascular resistance, which may fall fairly radically after surfactant or after nitric oxide, which has been confirmed from several observation studies, the perfusion of the brain now will change from low flow, potentially to high flow, given the fact that the left to right ductal shunt is modulating preductal cardiac output. So are we increasing the likelihood of an ischemia reperfusion event? Some evidence for this comes from Martin's early low SVC study, and this is actually low right ventricular output, showing that infants with the lowest flow in the first 6 hours were more likely to get IVH. This is some work from Shahab Nouri demonstrating that babies with a stable cardiac output tend to not get IVH. Patients with a low output that rises rapidly in the first 36 hours seem to represent a population of higher risk of IVH. And again, just what we've spoken about is the ductal shunt modulating these changes in flow. So this formed the basis for the screening plus targeted approach to hemodynamics in Iowa. And I'm not going to go into all great details, but basically, this is a disease or phenotype-based approach, of which one of the strategies is early modulation of the PDA shunt. And the scoring system was based on a composite of a Phi-Alpha score, which demonstrated a strong association with death or BPD. And that was based on this very elegant natural history study, where you can see that infants who had a persistent large PDA had higher flow in the pulmonary vein, higher left ventricular output, and compromised flow systemically, with changes as early as day 2. So the Iowa PDA score is based on the parameters here. And again, we don't have time to go into detail. We can maybe in the question and answer session talk about them. But if you reached a threshold of 6, we prescribe acetaminophen. If the shunt is persistent after 3 days, we extend it to 7 days, after which we will then give a traditional indomethacin or percutaneous device closure approach. So why acetaminophen? In our center, acetaminophen was chosen because many of our patients are receiving co-administration of low-dose hydrocortisone in the transitional period. If you look at Shovik Mitra's very elegant heat map, it shows that ibuprofen, particularly the high oral dose, seems to have the highest likelihood of PDA closure. Unfortunately, at the time, there were very few patients who actually received intravenous acetaminophen. Most of the work was based on oral acetaminophen, which is biased by the fact that that was tended to be used as rescue. But still, for acetaminophen, the area under the curve was still fairly high. Where I don't believe we're sure is how does acetaminophen work? Some work with Jeff Reese suggested that it took very, very high doses, superhuman doses, to vasoconstrict the rat ductus. Some work from Jacques Bellic in Toronto suggests that acetaminophen may actually induce an elevation in pulmonary vascular resistance through its pulmonary vasoconstricting effects. Interestingly, so does indomethacin, so does ibuprofen. So given that the ductus may not be architecturally designed to close with direct vasoconstriction, is an alternative mechanism of closure that we're slowing down the reduction in pulmonary vascular resistance, allowing there to be less flow across the ductus, potentially allowing ductal closure. And interestingly, in some of the patients that we follow that we've not treated in the first day or so, some of these patients with bidirectional PDAs in the first 12 hours actually are the ones that are more likely to close spontaneously. So flow is determined, as we mentioned previously, by a whole range of things. This is the Hagen-Fossett principle, which shows that flow is influenced by pressure differential, the diameter or radius of the vessel, the viscosity, and the length. And these are important considerations when one is thinking about how can you also limit flow. Increasing PVR by inducing vasoconstriction with carbon dioxide, avoiding excessive oxygen exposure, and the use of PEEP are strategies that one can use and have been applied in the single ventricle physiology population. I think it's important to recognize, despite the fact that we practice it in Iowa and many centers practice it and believe in it, there's actually not a lot of evidence to actually support these strategies. Other important consideration, dangers of fluid restriction. This is the study from Van Boost in Belgium, which showed that when patients were randomized to a much more aggressive fluid restriction, PDA diameter didn't change, but flow to the brain or systemic blood flow did in a negative manner. So for my last couple of slides, I just want to share not the whole impact of the epoch-based intervention in Iowa, but within the subpopulation of infants who had a diagnosis of PDA in the prior epoch, in which practice was late diagnosis beyond at least day 5, mostly beyond day 7, the use of indomethacin as a first-line therapy, followed by PDA surgery, compared to the modern epoch that we've described. What you can see in this cohort is that there were factors that potentially were favorable in the modern cohort, such as a higher rate of delayed cord clamping, more use of magnesium sulfate, but factors that would be concerning also: higher risk of breech presentation. Maternal obesity was almost 3 times higher. Maternal SSRI use and so forth was higher. Interestingly, the subpopulation of infants born at 22 to 23 weeks increased from 22% in the historical cohort to 45% in the modern epoch. This is the results of the primary analysis. And what you can see here is that the composite of death or severe, meaning grade 3 BPD, was significantly reduced. Death was reduced. Early death was reduced. Significant IVH in this population was almost halved. And probably the most striking finding for me was that NEC was pretty much abolished in this subpopulation of infants that required PDA treatment. These are the results of the logistic modeling that was done and showed that after adjustment for both the favorable and unfavorable factors, that early screening appeared to be independently associated with a favorable outcome for these babies. So, to sum up, PDA is associated with major neonatal morbidity. However, it's very clear that randomizing babies based on diameter alone, or diameter with left to right shunt alone, is not beneficial. That is clear from the trials. However, the evidence is only as good as the certainty of the disease, as we have pointed out today. And personally, we have not yet performed a trial of a subpopulation in whom we've been able to guarantee persistent exposure to a high volume shunt. Some evidence that early targeted treatment may positively modulate outcomes. Again, caution, this is applicable to the Iowa cohort. We need to wait for evidence from other centers. I've personally seen data from Chile and some other South American data that suggests that this may be a favorable direction, but this needs to be confirmed through well-designed randomized trials. So I'm going to stop, and I'd be happy to take time for questions. And I just want to acknowledge that the bulk of the work on screening, particularly PDA, this was Reagan's work, and she has left an amazing legacy behind. Thank you very much.
Thank you very much, Patrick. That's a fantastic overview of kind of the physiological landscape and treatment landscape. It's certainly a controversial topic, so I'm looking forward to the discussion. We always get some lively discussion and debate. I'm just going to share my screen